Hi everyone. Better make a start. So I'm Louise. I'm on elderly medicine at the moment, and I've come to talk about the explaining and counselling OSCE, which is potentially a bit of a dry topic. So I'm going to try and keep it brief, give you a few examples, and I've got some sweets as well, which is always good. So I'm just going to talk about what the curriculum says about communication skills that you need for OSCEs. I'm just going to remind you that you have all these skills already. I'm going to talk through a few stations that could come up in finals, so like counselling OSCEs, talking about complaints and breaking bad news, which I've already been through before. And I'm going to pop in last year's OSCE stations that I remember on this topic as well. And then there'll be time for some questions at the end. So I just lifted this from the core curriculum just to remind you about the things that you're meant to be doing in OSCEs and in life as an F1. So it's just communication, handling aggression. You might get something like the angry relative or something like that. Taking a supportive role in breaking bad news. So as an F1 or any junior doctor, you'd never be expected to break bad news on your own. It's not really fair on you or the patient or the relatives. And then just explaining basic procedures, checking the patient's understood, etc. So I just wanted to remind you, you've all done OSCEs before, you know what it takes to have a successful OSCE station, the importance of just making a good impression at the start, being confident, setting the scene right, just making sure you've got the right patient, etc. Always remember ICE in every station. They love it in Leeds. Always summarise, check the patient's understood, thank them at the end, and then just remember your timekeeping as well, because in these counselling type stations you're sometimes expected to do a little bit of history and then move on to the counselling, but they often don't tell you when you actually need to move on, so it's just important to really read the question carefully and just understand what they're trying to get from the station. So the first thing I'm going to talk about is counselling stations. So explaining a procedure or a treatment, or you get some results that you have to explain to the patient. So first of all, you need to find out what the patient already knows about their condition or whatever test they've had and what they want to know. And it's, you really have to put it in their language, so, put it in really simple language. You don't have to use any medical jargon or anything. Some people like to draw diagrams if they're explaining things. That might, come in handy. And then offer them some written information at the end. And that thing at the bottom is just about informed consent, but you shouldn't be consenting anyone in the OSCE. That one. I got this from the well-known revision guide that's been kind of circulating well.
Have you all got hold of that?
Brian Macmillan's OSCE guide. Everyone?
That's basically all the OSCEs that you'll get tested on, unless they've changed them all. DNAR is quite it comes up quite commonly, and I think the important thing to remember with that one is that the DNAR is quite strict in what it's actually talking about. So it's only talking about cardiopulmonary resuscitation. It's not talking about anything else. So they might have come in, the likely patient has come in with sepsis, has gone into acute kidney injury, and you're treating them with IV antibiotics and you're giving them fluids, and the family are concerned because one of the senior doctors has filled out a DNAR form, and the impression that the family's getting is that you're going to be stopping treatment. And it's important to stress that no, you're still actively managing the sepsis and the acute kidney injury, but if this lady or gentleman were to crash, so their heart was to stop beating, or they were to stop breathing, that you then wouldn't pursue resuscitation. And a lot of people don't really understand that in the public, so you've got to be just really clear with them and explain that it doesn't mean that you're going to stop treating their sepsis and their acute kidney injury, and that if you do treat that over the next couple of days and things do improve, then you might reassess the need for the do not resuscitate order. So that's one that's in Brian Macmillan's book as well. We have smoking cessation we didn't really get. And the other two, I think, so sigmoidoscopy results and explaining inflammatory bowel disease, about Crohn's and or ulcerative colitis and the effects that they can have on your lifestyle and things after that. That's come up before. And I think
it's impossible to predict what's going to come up. I think they do like to repeat stations, don't they? But they thought of a new one for Friday, which is good.
Anything else?
More questions, I think?
Any other questions at all about anything else? Yes, they have been